Okay, so this video tutorial is just on the basics of filling in a pain chart. Now, you get lots of different pain charts. This is just one example of them. You'll just have to work with whatever you use in your trust or your environment where you're working. But essentially, there are a number of components that you need to get onto this chart. The information that we typically contain on the chart is the presenting condition or presenting complaint, and that consists of some information around how the symptoms are presenting or what the patient's saying about the symptoms. The first thing then is to clearly demarcate on the chart where the symptoms are. So for argument's sake, if we say that the symptoms with this patient are located in this area near the lumbar spine, on the right, and just into the actual buttock. Okay. Now I often find it's easier if you just get the patient to indicate when you're interviewing them where they are, because they're able to show you the sort of lines or demarcation of exactly where the symptoms are. Once you've established that that's the only area of pain, or if there's other areas, obviously chart them on, you need to label it. Now typically these used to be labelled P1, P2, P3, etc. Or respectively, but the problem with that is that people often get the P mixed up with pain. So I'd suggest that for ease and to save confusion, you just label them A, B, C, D, etc. The next thing to do is just to close off the rest of the pain chart. And what I mean by that is just check and tick the rest of the pain chart so there's no ambiguity, and when you pick up this set of notes again, it's very clear where the symptoms were when you first looked at them. So you've asked the patient, so what you need to do is tick off all the other areas, and you tend to go for like major joint areas, so head, sort of shoulders, cervical, thoracic, and this part of the lumbar, because we know that this bit here is involved, elbows, hands, this side here, backs of the knees and feet, and equally do the same on this side as well. So head, shoulders at the front, elbows, hands, like thoracic area, abdomen, like hips, knees and feet. That's quite clear now that you've got one set of symptoms and it's on the right hand side of the body, and we're quite clear where it's located. The next thing we need to write down is the type of pain and get some details about it. So we want some descriptors from the actual patient, so how are they describing it? And patients will use all sorts of different descriptors. It doesn't matter, just write down what they're saying. You might need to, where possible, don't do this, but you might need to give them some descriptors to work with. But let's say the patient's reported this as an ache. Okay. Well, we need to know a little bit more detail than just that it's an ache. So is it deep or superficial? And this might indicate whereabouts the actual problem is. Let's say they report it deep. And what type of ache is it? Is it on and off? Does it change? Is there any variability into it? So is it constant or intermittent? Now also be aware that if you get a constant report from a patient, that's something that, if it's there truly all the time, it's something to investigate much more further. But for argument's sake, for the sake of this exercise, let's just say it's intermittent, and I'm just going to abbreviate that with IM, which is quite common. We need to know a little bit about how they describe that ache. So, although that might be like aching in that area, are there any other like symptoms anywhere else? And this is a good indication of the type of pain mechanism. So be it nociceptor local, referred, peripheral neurogenic, or centrally maintained. So if they're using words like lancinating, emanating, tickling, or any unusual sort of language, it's giving you a good indication, potentially, of what sort of pain mechanism. Now, one thing I haven't noted is that, I've just striped this area here, but when we fill in sort of symptoms, you sometimes see this. So stars are often used to indicate pins and needles. Obviously, they're over the area where they are. Sometimes you'll see people indicate arrows in this direction, which is indicating that the symptoms are travelling in a particular direction. And sometimes you see dots like this, which are usually there to indicate that there's some sort of pins and needles or numbness. Okay, once you've got this information down, you need to establish what these symptoms are doing. And we do this by what we call aggravating and easing factors. Generally, just write something like this: aggs, eases. And this is really important, this bit, because this is going to give me a good idea about what the patient does to make the symptoms worse, and then what they've worked out they do to change the actual symptoms. And if possible, it's good to get a timing or an event alongside when they describe their aggravating easing. So let's say that this patient describes their aggravating factors as bending. Bending forward or flexion in our language. What I really want to know is when you bend forward. Does it come on straight away? Does it take some time for it to come on? Is it a number of repetitions it takes to come on when you bend it? And for argument's sake, let's say that they say straight away. Okay. I now want to find out the association between the aggravating factor and the easing factor. Now, this is a difficult thing to do because not all patients can tell you this, but essentially, when you come back up straight, does it go away? Or do you have to do something else? For argument's sake, let's say this patient says, well, I have to lay on the floor and put a pillow under my arms like that, so I'm getting into essentially an extended position, and it takes about 10 minutes for it to dissipate. So that would be prone, lying, with a pillow equal to 10 minutes. Alright, and now we've got a nice little pattern showing to ourselves there, so we can see that if they bend forward, it comes on more or less straight away, quite acute. However, if they lay down on the floor for 10 minutes, it goes off relatively quickly. Following this, we need to get our 24-hour pattern. So if we put that up here for argument's sake, and we want to know how these symptoms behave over a period of 24 hours. So the sort of questions that I would ask a patient is before they even get up. So before up, what are the symptoms like? So before they get out of bed, right? Immediately when they've got up, what are the symptoms like? During the day, i.e. if they're working or doing other activities, how do your symptoms behave during the day? On an evening, and that might be when they're relaxing, okay, how the symptoms behaving, and then finally at night, and particular with regard to sleep. So how they're sleeping, is it disturbing them? If it is disturbing them, how many times? Okay, and that's quite nice information to get down, because you can link that information into your aggravating and easing factors, and it'll often start showing you patterns, possibly like likely pathologies, and it might also start indicating to you where you're going to go in regard to your objective assessment, and then probably where you're going to go with your treatment or management. Once you've got this information down, you need to score the patient's pain, and typically we use a VAS or VAS scale, which is a visual analog scale, and we normally mark it between 0 and 10. So you can draw a line on there, put a 0 and put a 10. Now, rather than just getting a blunt reading here, I mean it is blunt to some degree, but what I'll say to patients is, where is your pain right now? And let's say they indicate that it's 5 out of 10. Okay, so I'll put that there, and I'll put an N. Okay, and I'll put the corresponding problem. So their A symptoms are about 5. And when you've really aggravated it, where would you say your pain is? And let's say they say a higher number, like 8 for instance. Okay, I'll put a W meaning worse, and then an A indicating that that's the symptoms we're talking about. Okay, with the special questions, initially we'd want to ask about the cord, special questions, so whether there's any bilateral pins and needles or indeed quadrilateral pins and needles, and any alterations in the gait pattern, so as they're walking, changed at all since they've whatever the mechanism of injury is, or since they've noticed the back pain. And with regard to the cauda equina, the first prognostic indicator is any changes in saddle anaesthesia and paresthesia. So you just got to think about how you ask that question. So perhaps you might want to use terminology such as as you clean yourself when you've been to the toilet, have you noticed any numbness or pins and needles in that area? And then really about bladder and bowel function, so any loss of control, retention, hesitancy, urgency, sense of incomplete evacuation. And then finally, if you cough and sneeze, does it make any difference to your symptoms? The last thing really to get on this pain chart then would be the sin factor, and the sin factor is essentially going to help you decide how vigorous or how much of the objective examination you should do with this particular patient. The S is for severity, the I is for irritability, and the N stands for the nature. So at this stage, is it more of a mechanical problem, or is it more of an inflammatory problem, or have you got the two components of either mixed together? But again, we'll talk about this more as we move on in the module.